Hey everybody, I'm Dr. John Willardsen, and today we're going to discuss, we do a lot of cases here where we do full mouth reconstruction, all on 6, all on 8, but today we're going to look at a single tooth replacement. So just the extraction, bone graft, implant, placement of the implant, and then the fabrication of the provisional. So immediate loading and immediate placement. And I love this, I love doing this procedure because you get such an instant result, instant satisfaction. Patient comes in with a fractured number 7, crown is fractured off, the root is fractured at the gum line, and so we go in and we start the process extracting the root of the tooth and very gently removing the root so as to not damage the buccal plate and to maintain the integrity of the soft tissue and the bone as much as possible. And so as we're doing this procedure, we elevate the root out using periotomes and very gently massage the root out of the alveolus, and then degranulate the alveolus, clean it up, make sure there's no granulation tissue or soft tissue left behind. And then we go ahead and we start the osteotomy preparation. And notice as I'm placing this or preparing that initial osteotomy, I'm pushing to the palatal, kind of staying away from the buccal plate because I want my screw to be in the palatal direction, kind of more on the palatal side. And so you can see there I've got my initial drill, my 2.0 drill in place. We take an x-ray of that, and then once I know my orientation as to the adjacent teeth, I can go ahead and finalize this osteotomy. So I open up the aperture of the osteotomy and begin the process of creating the hole or the osteotomy where I'm going to be placing this implant. And we'll be placing a 4.3 by 11.5 Noble Tie Ultra. So we get good fixation of that bone because it's a screw that has really aggressive deep threads. As I'm preparing the osteotomy, I go to my 2.0 millimeter drill, then I go to 2.8. And then at this point I make the decision, am I going to open up the aperture of the osteotomy more, go to a 3.2 because I'm placing a 4.3. So I want to stay and keep that osteotomy under prepared. And so as a result, I will go ahead and stop at 2.8, and then I'll use an osteotome to open up the aperture of the osteotomy. Grafting, of course, because I'm grafting the buccal area of the implant. I've pushed my osteotomy to the lingual. I'm grafting the buccal and using osteotomes to open that aperture. And I stop at a 3.5 osteotome so as to, when I place a 4.3 implant, I have really good, solid, rigid fixation of the implant. And so as you can see here, we've got that, as the implant goes in and drives into the osteotomy, I can feel the resistance back on my handpiece. I can feel that I've got good, rigid purchase of the apical aspect of the osteotomy and the bone. So that implant is going to be in a nice solid position. And as a result, it allows me to go ahead and start the loading process and fabricating or putting a custom abutment on there, which was an abutment we had previously. So we went ahead and we just contoured it back and made the provisional so that we could load this case immediately. And what that does is it allows the soft tissue contours to maintain the same. So I always will my preference is to do this on these anterior cases because it's going to preserve the soft tissue and the hard tissue. And in the end, you can't tell if it's an implant or a natural tooth because we have not made an incision, I haven't raised a flap. I'm feeling for that buccal plate. When I extract the tooth, I want to make sure the integrity of the buccal is intact and then start the osteotomy preparation. Use osteotomes to kind of finalize the osteotomy with graft material, and then go ahead and place the implant, the abutment, and then the crown. Once the abutment is in place and the crown, of the temporary crown, of course, and the temporary is fabricated, we go ahead and contour that temporary so that the emergence profile out of the soft tissue is optimal, and the body will start, as it's regenerating or healing, it's going to adapt right around that crown or temporary and abutment to provide a really nice soft tissue contour. This is a great example of doing an immediate placement. So extracting the tooth, bone graft, placing the implant, and immediate loading. So we made the provisional on the implant at the same time as we placed the implant itself and did the extraction. So I'm Dr. Willardsen. So if you'd like more information, visit our YouTube channel at Trust Implants, or the Trust Institute, and we've documented as many procedures as we possibly can so as to educate patients and practitioners to elevate the level of their practice. I'm Dr. Willardsen, and thanks for watching.